Hi guys, this is Kathleen. I'm going to speak to you about anemia. There's a lot of information on this lecture, and please don't stress. We'll go over a lot of it in class, and it's a lot, but it's fun once you get the hang of it, and there's a lot to know. And some of you already work with CBCs all the time, so this will be just more of an in-depth review, if you will, but much more in-depth on when you have to present with patients and figure out what type of anemia they have. Okay, anemia is defined as a reduction in the number of red blood cells, hemoglobin, or hematocrit concentration. Here are the labs. A man's hemoglobin less than 14, hematocrit less than 42. Woman's hemoglobin less than 12 and hematocrit less than 37 is considered an anemia. This is typically classified based on the shape or the size of the erythrocytes. There's over 400 types of anemia. And anemia is not a disease, but rather a sign, a symptom of an underlying disorder. So what we look at on the WBC, on the CBC report, we look at the white blood cell count, which is a count of the actual number of white blood cells per volume of blood. Both increases in white blood cells and decreases in white blood cells can be significant. We also take a look at the red blood cell count, and this is a count of the actual number of red blood cells per volume of blood. And again, both increases and decreases can point to abnormal conditions. We look at hemoglobin, which measures the amount of oxygen-carrying protein in the blood. Remember that. Hemoglobin measures the amount of oxygen-carrying protein in the blood. We also take a look at hematocrit, which measures the percentage of the red blood cells in a given volume of whole blood. We take a look at the platelet count, and it's the number of platelets in a given volume of blood. Both increases and decreases can point to abnormal conditions of excessive bleeding or clotting. There's also, we take a look at mean platelet volume, which is a machine-calculated measurement of the average size of your platelets. New platelets are larger, and an increased MPV occurs when increased number of platelets are being produced. An MPV gives you, the provider, information about platelet production in your bone marrow. Mean corpuscular volume is a measurement of the average size of your red blood cells. The mean corpuscular volume is elevated when your RBCs are larger than normal, which is labeled macrocytic. For example, in an anemia caused by vitamin B12 deficiency, that is a macrocytic anemia. When MCV is decreased, your RBCs are smaller than normal, and that's labeled as microcytic. And this is seen in iron deficiency anemia or thalassemias. Mean corpuscular hemoglobin is a calculation of the average amount of oxygen-carrying hemoglobin inside a red blood cell. Macrocytic red blood cells are large, so they tend to have a higher MCH, while microcytic red blood cells have a lower MCH. Mean corpuscular hemoglobin concentration is a calculation of the average concentration of the hemoglobin inside a red blood cell. It's the average concentration of the hemoglobin inside a red blood cell. Decreased MCHC values, hypochromia. So decreased MCHC values, hypo, chromia, are seen in conditions where the hemoglobin is abnormally diluted inside the red blood cells. And these are conditions such as iron deficiency anemia and thalassemia. And increased in MCHC, which is hyperchromia, are seen in conditions when the hemoglobin is abnormally concentrated inside the red blood cells, such as in burn patients or genetic spherocytosis, which is spelled spherocytosis, a relatively rare congenital disorder. So when we look at MCHC, which is mean corpuscular hemoglobin concentration, normochromic is 32 to 37, and less than 32 is hypochromic. Red blood cell distribution width, RDW, is a calculation of the variation in size of your red blood cells. In some anemias, such as pernicious anemia, the amount of variation, anocytosis, I'm sorry, I'll spell that again. Sorry, I did that a little fast. ANISOCYTOSIS in red blood cell size. So anocytosis is the amount of variation in red blood cell size, along with variation in shape. The shape is poikilocytosis, and I will spell that out for you, which is POIKILOCYTOSIS. And that has to do with poikilocytosis, has to do with shape, and this causes an increase in red cell distribution width. 3 general causes of anemia. Before I go into that, I just wanted to talk a little bit about red blood cell formation. This red blood cell formation is formed in the bone marrow, and this is called erythropoiesis. When mature RBCs are released into circulation. And basically, the mature red blood cell has a lifespan of approximately 120 days. Many factors trigger an increase in the production of red blood cell production by the bone marrow. But a decrease in oxygen is the most common. Low tissue oxygen levels trigger the endothelial cells in the kidneys to secrete erythropoietin, which in turn stimulates bone marrow red cell production. And that's probably one of the most important things that you learned throughout your undergraduate and graduate degree. So make sure that you review a little of that, and I'll talk more about that later, to truly understand what red blood cell formation is all about. So getting back to 3 general causes are blood loss, and these can be due from chronic bleeding, which can be due from GI, which can be due from ulcers, hemorrhoids, gastritis, and cancer. Nonsteroidals can be a cause of blood loss. Menstruation and childbirth in women are also another example of blood loss. You can have a decrease of faulty red blood cell production, and that is labeled as hypoproliferative anemia. And these are considered iron deficiency anemia, vitamin deficiency, B12 or folate, bone marrow and stem cell problems, chronic kidney disease, which is what happens with chronic kidney disease. You have a decrease in erythropoietin production, hypothyroidism, and other chronic diseases can cause this faulty RBC production, like cancer, infections, lupus, and rheumatoid arthritis. Hemolytic anemias are really a destruction of the red blood cells. And these are like sickle cell disease, sickle cell anemia, thalassemia, transfusion reaction, spherocytosis, SPHEROCYTOSIS, which when they look under a microscope, they see the presence of spares. Hemolytic anemia is due to G6PD deficiency, and which is genetic. An inappropriate attack of the immune system, which is that Rh incompatibility. Hemolytic anemias can also be caused by infection, such as malaria or certain chemicals or toxins. There are 3 classifications of anemia. Microcytic, where the red blood cells are small and the mean corpuscular volume is less than 80. That's microcytic. Normocytic, the mean corpuscular volume is 80 to 99. And macrocytic are large red blood cells with the MCV greater than 99. G6PD deficiency, that is a hereditary abnormality in the activity of the red blood cell, the erythrocyte. So classification of anemia, just like I had told you, MCV less than 80, it could be iron deficiency, thalassemia, sideroblastic anemia. And sideroblastic anemia is a disease in which the bone marrow produces ring cytoblasts rather than healthy RBCs. The body has iron available in cytoblastic anemia but cannot incorporate it into the hemoglobin. Cytoblasts are precursors to mature red blood cells, but in cytoblastic anemia they are atypical and do not progress to red blood cells as they should. Macrocytic anemia is an MCV greater than 99. This can be caused by vitamin D deficiency, folate deficiency, hypothyroidism, excessive alcohol use, and myelodysplastic syndrome. And that's basically what that means, is formerly known as pre-leukemia. This is like a diverse collection of hematological medical conditions that involve ineffective production of the myeloid cells in the bone marrow. Normocytic anemia, MCV of 80 to 99, that can be sickle cell anemia, anemia of chronic disease, aplastic anemia, or hemolytic anemia. Most common type of anemia in primary care is iron deficiency anemia. So basically the pathophysiology is that iron loss exceeds intake, so that stored iron is progressively depleted. As storage iron is depleted, okay, this is the pathophysiology, a compensatory increase in the absorption of dietary iron and in the concentration of transferrin occurs. Once iron stores are no longer able to meet the needs of the erythroid marrow, the plasma transferrin level increases and the serum iron concentration declines, resulting in a decrease in iron available for RBC formation. Remember that the liver produces more transferrin in attempting to maximize the use in the attempts that the iron is unavailable. Transferrin is really stored iron. Transferrin is a plasma protein that transports iron through the blood to the liver, spleen, and bone marrow. And this reflects iron transport. So transferrin is a plasma protein that transports iron through the blood to the liver, spleen, and bone marrow, and reflects iron transport. So I'll say that again. Transferrin, a plasma protein that transports iron through the blood to the liver, spleen, and bone marrow. And this reflects iron transport. So as we look, there's a kind of points that I wanted to take about what happens when someone has iron deficiency anemia. The first thing is that the ferritin decreases, and that's the storage compound for iron. These are decreased iron storage. The marrow is decreased and it's exhausted of its own iron. Serum iron decreases, levels bounce around due to ingestion of iron. Red blood cell width distribution increases. Highlight that. That is an early finding. New cells are paler and smaller with iron deficiency anemia. Total iron binding capacity in iron deficiency anemia increases. Lots of spots available for iron to bind. So total iron binding capacity increases. And the hemoglobin decreases. Indice decreases. These cells are small and they're pale. So to wrap up, in adults typically occurs as a result of bleeding. In children and adolescents typically occurs due to inadequate dietary intake and increased demand for iron. Patients when you take a look at their CBC, you might see a normocytic, normochromic in early stages. Causes of iron deficiency anemia. Blood loss, GI loss, menstrual loss, blood donation. Increased physiological requirements such as pregnancy and lactation. Inadequate iron supply, insufficient dietary iron. Impaired iron absorption can be one of the reasons. Gastric surgery, which what happens is when you bypass the duodenum on the gastric bypass, that is the area of absorption that you're bypassing. So that's why patients who have had gastric bypass have iron deficiency anemia. Intestinal malabsorption, celiac disease causes iron deficiency anemia by reducing iron absorption. And lead exposure also causes iron deficiency anemia. Signs and symptoms of iron deficiency anemia are fatigue, palpitations, dyspnea on exertion, lethargy, headache, pica, which is an eating disorder characterized by the desire to eat non-nutritive substances like starch, clay, ashes. And this can be due to increased lead absorption. Patients are pallor. You might hear a heart murmur due to iron deficiency anemia, angina, tachycardia, tachypnea, orthostatic hypotension, and the wide pulse pressure where the systolic and diastolic go farther and farther and farther away from each other. Diagnostic studies for iron deficiency anemia. And I do want to, diagnostic studies for iron deficiency anemia. Low hemoglobin, low hematocrit, low serum ferritin. And that ferritin, I think on the last PowerPoint I might have misrepresented what it does, so I want to repeat it again. I did repeat it over and over again, but ferritin is iron storage and transferrin is iron transport. That's real important to know. So ferritin is iron storage and transferrin is iron transport. So low serum ferritin, which is the iron storage, increased total iron binding capacity, low serum iron, low transferrin saturation. The retic count is elevated in blood loss, and it's decreased in iron deficiency anemia. So total normal serum levels in a male is 76 to 198. In females, it's 26 to 170. Remember that iron levels are just blood levels, and that's important to know because when we look at other lab work, we want to look at what's really important, and the iron level is not as important as the iron storage level. So total iron binding capacity is 262 to 474. Transferrin, again, is iron transport, which is 204 to 360, and these are normal ranges. And ferritin for a male is 18 to 250, and for a female, 12 to 160. And again, ferritin is iron storage. Reticulocytes are an early immature form of a red blood cell. Transferrin is a plasma protein that transports iron throughout the blood, and that occurs in the liver, spleen, and bone marrow. So treatment for iron deficiency anemia. The most important takeaway message is find out why, okay? Because a lot of people are going to say, oh, I've always had anemia. It's our job to diagnose and make sure that you don't just assume it's iron deficiency anemia. You want to find out why. Why are they having that? They might need a colonoscopy. They might need an upper GI series, an endoscopy, a chest x-ray, urinalysis, or endometrial biopsy. Now look at, this is not, I just listed a bunch of those, but that's not what we do for every person that comes with iron deficiency anemia. We have to take a good review of systems. Look at, are they guaiac? We do a rectal exam. Do they have occult? Are they heme positive? Because that's really important. You can have just a small amount of blood, okay, that's not, that is seen in the stool, okay? But it's not even seen visually. It's occult, meaning not visible. So we're gonna talk a little bit more about that. Establishing underlying cause, big takeaway here. We are going to treat patients with ferrous sulfate, 325 milligrams. It says TID, never give it TID. That's a new evidence that came out, just BID. BID is more than enough. And that's kind of a new practice, BID. Improvement will be within 4 weeks. Continue therapy for, it says 3 to 6 months, 9 months. It takes at least 3 to 6 months just to replenish the iron storage. So they're going to be treated for at least 9 months. We're going to tell them to eat foods that are rich in iron, like liver, beef, lamb, pork, veal, chicken, eggs, fish, beans, prunes, green leafy vegetables. We're all very good about, nurses are really good about teaching patients, so I don't want to spend a ton of time on that, but just a review on what is high in iron is important as well. Now, if they cannot tolerate the iron, there's always IV, iron dextran, weight-based, and that's for people that are intolerant to oral replacement. For individuals with GI disorders that inhibit absorption, or they're unable to use the gut. This is very, very expensive, so you want to try everything that makes sure the patient can take it orally, before you go to IM. There's also Nephronex, which is 150 milligrams, which is iron, and Repleva, taken 21 to 28 days. The side effects of IV iron is anaphylaxis, phlebitis, regional adenopathy, serum sickness type reaction, and staining of IM injections. The real important thing is that the bleeding source must be identified in men and women who are not menstruating or pregnant. Even really, really important. 50% of individuals, there was a study done, it's called the KREPZEK study. You can Google that or look it up. 50% of individuals diagnosed with iron deficiency anemia all had pathology. 50%. They either had cancer, gastritis, esophagitis, gastric ulcer, duodenal ulcer, adenoma, hemorrhoids, and vascular malformation. So when someone comes in with anemia, this is going to be your challenge. You need to find out why they're anemic. We need to educate patients taking iron sulfate. Foods taken concurrently may interfere with the absorption. Vitamin C taken with iron enhances absorption, so you want to tell them to take it with vitamin C. Mild antacids interfere with absorption, so you want to make sure that they don't take that. Iron can cause constipation. I love, my go-to is fiber gummies. I love them. They really help, and patients are very compliant with fiber gummies because they don't think they're taking a pill. We want to follow up these patients. If you have a menstruating woman, you want to follow up in 3 to 4 weeks for repeat exam of hemoglobin. If they're anemic, you want to treat, and you think it's due from the period, you want to give them ferrous sulfate. Of course, you're going to have them follow up with OBGYN if you don't manage that in your office. And then you're going to start them on it, and when they come back in 3 to 4 weeks, you're going to look at their reticulocytes, because if it is iron deficiency anemia, you're going to have an elevation in the number of reticulocytes. Hemoglobin and hematocrit should be repeated 6 months after successful treatment. If you're concerned about the diagnosis, if you really don't know if it's iron deficiency anemia, Order a retic count in 7 to 10 days after initiation of iron therapy. And again, the reticulocytes should increase within 7 to 10 days. And so the patient presenting should have reticulocytosis if they have iron deficiency anemia. Macrocytic anemia, there's also thalassemia. And this is a genetic inherited syndrome. And this is due to an abnormal synthesis of alpha and beta hemoglobin change due to a defect in the genes controlling production. There are 4 genes that are alpha chain, that control alpha chain production, and 2 genes that control beta chain production. There are 3 types of thalassemia. This thalassemia minor, which typically has little or no hematological effects, or possibly a mild microcytic hyperchromia anemia that is often mistaken for iron deficiency anemia. Thalassemia intermedia, moderate microcytic and hyperchromic anemia that is not transfusion dependent. These patients may develop persistent clinical problems such as pathological fractures, abnormal facies, growth retardation. If this develops, patient is considered to have thalassemia major. And thalassemia major is severe life-threatening anemia during the first year of life. It's associated with developmental problems, decreased life expectancies, require lifelong chronic blood transfusions to maintain adequate hemoglobin levels and iron chelation. The only cure for thalassemia major is a bone marrow transplant. And remember that a microcytic anemia is an MCV of less than 80. So here we have the comparisons of finding iron deficiency anemia versus thalassemia. So in thalassemia minor, you have a decreased MCV. Same with iron deficiency anemia. You have a decreased mean corpuscular volume of less than 80. You have a decreased MCHC, which is less than 31. You have hypochromic RBCs in both of them, which are pale. Chromic meaning color. They're both pale cells. You have a decreased hemoglobin and hematocrit, as well as with thalassemia and anemia. In thalassemia, you have an increased red blood cell count. In iron deficiency, you have a decreased red blood cell count. You also have a red cell distribution width, which is RDW. And that basically, an increased red cell distribution width means that there's quite the variation in the width of the red blood cells. So you have a normal red cell distribution width in thalassemia and an increased red cell distribution width in iron deficiency anemia. So demographics of thalassemia, there's patients that have higher incidence of thalassemia, and they're on here. Laotians, which they are from Southeast Asia, if you've never heard of that. European Jews settling in Spain and Portugal are at higher risk as well for beta thalassemia, and it does occur in African Americans and Chinese. Signs and symptoms of thalassemia, alpha trait, usually if they're a carrier, they're usually asymptomatic. The alpha thalassemia minor, 2 of the 4 alpha chain forming genes are affected. Beta thalassemia minor, usually asymptomatic or mild to moderate. Microcytic, hypochromic meaning pale color anemia. Patients present with enlarged spleen or liver, bronze coloring of the skin. They get bone marrow hypoplasia. Beta thalassemia major affects both chain forming genes, which also is called Cooley's anemia. This is beta thalassemia major. Patients have severe anemia with cardiovascular burden, meaning they have shortness of breath, chest pain, CHF, fractures related to bone marrow expansion, retarded growth and maturation, and other side effects of iron deficiency anemia. Hemoglobin H disease, 3 of the 4 alpha chain forming genes are affected. On CBC, you're going to see the MCV is moderate to severe. And patients, you want to assess their abdomen. They usually have an enlarged spleen. Diagnostic studies for thalassemia. Hemoglobin is usually low. Serum iron is low. Now, this is with iron deficiency anemia. So if you look at thalassemia, I'm going to compare the two. So thalassemia, the hemoglobin is low. Same with iron deficiency anemia. Serum iron for thalassemia is normal or increased, can be. Same, serum iron is just low, okay, in iron deficiency anemia. Total iron binding capacity for thalassemia, total iron binding capacity is normal in thalassemia and increased in iron deficiency anemia. Ferritin, serum ferritin is low in iron deficiency anemia. If you look on the PowerPoint, it's normal or increased in thalassemia. Red cell distribution width is normal in thalassemia, but it's increased in iron deficiency anemia. The retic count is elevated in blood loss in iron deficiency anemia. It's elevated in blood loss with a retic count, and it's decreased in iron deficiency anemia. If you look at the retic count for thalassemia, it's normal or increased. Normal or increased. It's decreased in iron deficiency anemia. So again, hemoglobin electrophoresis, we look specifically at alpha and beta chains, and they're both decreased. Peripheral smear will show microcytosis, hypochromia, which is that pale cell. Patients might, on the CBC, might show target cells, and these are very abnormal blood cells. They also present, you can have this basophilic stippling, and that is not normal, and that is looking at the morphology and saying that there's stippling or target cells. Those are very abnormal cells. Target cells also associated with hemoglobin C disease. They can have skull x-rays, which shows widened marrow spaces in skull, long bones, and osteoporosis with thalassemia. The treatment for thalassemia, there's no specific treatment. You will have required to have genetic testing. You may need treatment with iron if you have coexisting iron deficiency anemia. You want to avoid iron overload. You might require regular transfusion to maintain adequate hemoglobin for normal growth and development every 3 to 6 weeks to maintain a hemoglobin of 9 to 10. You most likely will have iron chelation therapy to prevent complications of transfusion-dependent iron load, and that's administration of chelating agents to remove heavy metals from the body. Again, beta thalassemia major individuals require bone marrow transplant. Microcytic anemia or sideblastic anemia. Again, this is microcytic anemia. Anemia characterized by ringed cytoblast. This is caused by an enzyme disorder. The body has adequate iron but is unable to incorporate it into the hemoglobin. Iron enters the developing red blood cell. Iron accumulates in the mitochondria, giving a ringed appearance to the nucleus, and that's where you get these ringed cytoblasts, which are abnormal. This can be idiopathic or caused by genetic defect, toxin, or exposure. Causes of cytoblastic anemia are E2H abuse, lead exposure, isoniazide, chlorophenicol, which is an antibiotic, neoplasm, and inflammatory disease, carcinoma, leukemias, lymphoma, and rheumatoid arthritis. It also could be X-linked recessive sideroblast anemia. It also can be Pearson syndrome, which is a mitochondrial disease characterized by sideroblastic anemia. And this is found in in infants. And Pearson's disorder really is a disorder of infants, but it's an FYI for you to understand. So the vacuolation of marrow precursor cells, this basically, they develop vacuoles in the bone marrow, which are extremely abnormal. Diagnostic studies for sideroblastic anemia is microcytic anemia, basophilic stippling on peripheral smear, lead poisoning can cause that. Patients are going to have increased serum iron, increased ferritin and transferritin, decreased total iron binding capacity, decreased hemoglobin hematocrit. Bone marrow biopsy will show Prussian blue stain on bone marrow aspirate. And if some of you have looked at bone marrow results, you want to look at them, pay close attention, especially after this lecture, because when we talk about abnormalities and we're looking to diagnose certain anemias, leukemias, or cancers, oftentimes they will have abnormal findings that you've never seen before. Check blood alcohol and lead levels for this type of anemia. Depend on cause. Signs and symptoms of sideroblastic anemia may have a history of ETOH abuse, have altered mental status, abdominal pain, neuropathies, history of treatment of TB. Remember that one of those meds that the side effects causes that, fatigue, pallor, enlarged spleen, and cardiac arrhythmias. With sideroblastic anemia, you want to refer to a hematologist. Patients are going to be started on pyridoxine, large doses, 200 milligrams a day, beneficial in some, sometimes treated as myelodysplastic syndrome with epigen growth factors, may progress to aplastic anemia, which requires bone marrow transplant. Either way, you're not managing this. Your patients might be on those medications based on what the hematologist's recommendations are and what they prescribe. Normocytic anemia is anemia of chronic disease. Aplastic anemia or hemolytic anemia can also be an MCV of 80 to 100, which is in normal limits, but they can still have a low hemoglobin hematocrit. This anemia is caused by long-standing infections, TB, HIV, osteomyelitis, neoplastic disease such as cancer, or inflammatory diseases like RA and lupus. These processes block iron transportation from storage sites to bone marrow. They can be associated with renal failure and decreased erythropoietin production. And when we look at inflammatory disorders, they affect the RNA within your cell, these inflammatory disorders, and that's how this impacts the iron transportation and storage sites to the bone marrow. Second most common anemia after iron deficiency anemia. And yeah, okay. Diagnostic studies for anemia of chronic disease, CBC showing anemia low and normal MCV, normal iron studies or low percentage of iron saturation with normal to low total iron binding capacity. Elevated CRP or SED rate, that really is going to take a look at this inflammatory process going on that's causing this. Elevated BUN and creatinine. And treat underlying cause. Anemia is reversible if primary disease is controlled. Also, serum ferritin is normal or increased. Use this point to discriminate between anemia of chronic disease and anemia, iron deficiency anemia. Serum ferritin is low in iron deficiency states, and it is normal or increased in anemia of chronic disease. So remember that. Physical exam is guided by history since numerous inflammatory processes can cause chronic anemia, like chronic infections, cancers, And you always, always, always want to obtain a stool for occult blood. Normochromic, this is aplastic anemia, or normochromic normocytic anemia. It's caused by autoimmune suppression of hematopoiesis, and this is a condition of bone marrow failure. It arises from injury to or abnormal expression of the stem cell. It's idiopathic in over 50% of cases, 20% from drug or chemical exposure, 10% from viral, and it's most common in adolescents. So drug chemicals that can cause aplastic anemia are insecticides, benzenes, chemotherapy agents, and chloramphenicol. Those are drugs. Medications, antibiotics, antidepressants, lithium, tricyclics, anti-inflammatory drugs, antimalarials, and anticonvulsants. You'll see patients who have chronic seizure disorders, or some of them aren't been on lithium for years. They're at risk for this. Viral causes, non-A, non-B hepatitis, HIV, Epstein-Barr virus. Other causes is graft versus host disease, malignancy, or pregnancy. So benzene too, I might not have said that's from gasoline too, that may cause aplastic anemia. So normochromic mean corpuscular hemoglobin concentration is an MCHC of 31 to 35. So it's normochromic. That has to do with the mean corpuscular hemoglobin concentration, which is mean MCHC 31 to 35, which is mean corpuscular hemoglobin concentration. Normocytic MCV is 80 to 99. Risk factors for aplastic anemia: family history, pregnancy makes you at risk, exposure to toxins, which are benzene, which is it's gasoline. Toluene, which is a toxin in paint thinner, and insecticides. People can be exposed to benzene at work and the general environment, even though the use of some consumer products can cause this. The highest exposures have typically been in the workplace, although these have decreased greatly over the last decades due to OSHA regulations. Other exposures have also gone down over time, such as the amount of benzene allowed in gasoline. And signs and symptoms of aplastic anemia: fatigue, weakness, thrombocytopenia, purpura, and petechia. And I can't tell you enough, when you look at patient skins and they don't have petechia, write that on your exam. Neutropenia, they're vulnerable to bacterial infections. These patients are sick. There's a lot of patients that you remember that were really sick and just can never leave your mind. I've been a nurse a long time. And this is one of them. I had a patient with aplastic anemia almost 30 years ago. She was on chronic seizure medications, and that's how they think that she got this. But she was bleeding from every orifice, and she was very, very sick. I couldn't get enough blood in her. Platelets and RBCs. She ended up dying, but she was very, 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 very sick. Differential diagnosis for aplastic anemia: differentiate from other causes of pancytopenia, which is reduction in RBCs as well as platelets. Pancytopenia is a medical condition where there is a reduction in the number of red and white blood cells as well as platelets. We want to make sure, is this leukemia, lymphoma, myelodysplastic disease of bone marrow that does not function normally, megablastic anemia, an enlarged spleen, lupus, or infection. So megablastic anemia, the common cause of that most often is a deficiency in vitamin B12. And with aplastic anemia, these patients look like, if you've ever taken care of a leukemic patient, this is what they look like. Pancytopenia is hallmark, and again, that's a reduction in number of red blood cells, white blood cells, as well as platelets. Severe anemia, retic count is decreased, and that means there's a problem with the bone marrow. MCV is normal. Bone marrow aspirate shows hypercellular, meaning there's not a lot of cellular activity going on. So severe cases survival is less than 3 months without treatment. Neutrophils are usually less than 500. Platelets are less than 20. Retic are less than 1. And bone marrow cellularity is less than 20. Treatment for aplastic anemia, mild cases, supportive care, RBC and platelet transfusions, antibiotics to treat infections that are at risk. Severe aplastic anemia will require bone marrow transplant if they're less than 50. If they're greater than 50, they're going to require HLA matching siblings, or they will require immunosuppression, which is the most effective combination of drugs known today. One of them is ATG, which is an immunoglobulin, and this drug targets a type of white blood cell, particularly the T cells. And the T cells, as you know, are an important part of the immune system. The T cells basically direct the rest of the immune system when to attack foreign cells, such as those that cause infection. Cyclosporin is one drug, and this is a drug that targets T cells, and prednisone, a drug that causes the immune system to make fewer antibodies, and that is to reduce the side effects of ATG. Hemolytic anemia, sickle cell anemia, the most common, and then G6PD deficiency, which is an inherited erythrocyte enzyme deficiency that can result in acute hemolytic anemia, and this usually is precipitated by an infection or an ingestion of an oxidative drug. And oxidative drugs are sulfonic acid, hydrogen peroxide, which I don't know who would ingest that, but these can precipitate a hemolytic anemia. Hemolytic anemia, sickle cell anemia are chronic hemolytic anemias. They're sickle-shaped red blood cells. The etiology is autosomal recessive genetic disorder. Patients have an abnormal hemoglobin S, which develops in place of the hemoglobin A. It's a homozygous for hemoglobin S. Some have sickle cell trait, and it's prevalent in African Americans. The good news is one copy of this sickle cell gene is protective against malaria. This is why this is common in African American populations. They originate from an area where malaria is epidemic, and this sickle cell trait protects them against malaria. So sickling, when we think about sickle cell, they sickle, and this is a tendency of red blood cells to change from a bioconcave to an arch shape when oxygen tensions are low. This deformity results in abnormal hemoglobin molecules such as hemoglobin S, which is abnormal. These sickled cells clog small blood vessels, producing tissue ischemia and infarction. Most patients are diagnosed at birth. Most states currently have mandatory newborn screening for sickle hemoglobin. And as it relates to malaria, there are several studies that suggest that the sickling hemoglobin S that is found in sickle cell get in the way of the parasite that causes malaria. Signs and symptoms of sickle cell trait, patients are asymptomatic, but they also can be symptomatic, and usually that's when they present to the hospital because of vaso-occlusive issues from their sickling cells or severe hypoxia. So sickle cell anemia, they have sudden excruciating pain in the back, chest, abdomen, long bones due to vaso-occlusive crisis. They can have fever, jaundice, retinopathy, and a large spleen. And retinopathy is a disease of the retina that results in impairment of loss of vision. Diagnostic studies for sickle cell is a decreased hematocrit hemoglobin. The peripheral smear will show sickled cells. You have increased reticulocytosis, and those are immature red blood cells. You have an increase in those. You have hollow, jolly bodies, which will be found on the smear. You'll have WBCs typically elevated to 15,000. You'll have indirect bilirubin, which will be elevated. SICKLE-DEX is a test that measures how likely red blood cells are to sickle under conditions of reduced oxygen tension. So you want to get SICKLE-DEX testing as well. Treatment for sickle cell disease is genetic counseling, no specific treatment, prevention of acute vaso-occlusive crisis, folate 1 to 2 milligrams a day, pneumonia, vaccine, hydration, oxygenation. Acute crisis, you want to give liberal pain management, exchange transfusion, hydration, and oxygenation. Frequent crisis, patients need to see a specialist. Folate is given because hemolytic anemias consume large amount of folates due to rapid blood turnover. And folate is necessary for erythropoiesis. Supplementing allows maintenance of the higher rates of erythropoiesis. So patients are, if they have frequent crisis, they'll be on hydroxyurea, which is a chemotherapy agent, which reduces RBC count, particularly white blood cell count. And that is one exchange. Also, exchange transfusion. This is a medical treatment in which apheresis is used to remove one person's red blood cells or platelets and replace them with transfused blood products for those in acute crisis. Vaso-occlusive crisis occurs because this is due to increased rate of sickling, and the patients present with hypoxia. They can present with viral and bacterial infections. High altitudes can cause the crisis, emotional and physical stress, surgery, blood loss, and dehydration. One of the providers that we go to Haiti with talks about how these students have a camp every summer, and they have so much fun, and they end up coming back to the hospital because they're all so dehydrated and require that dehydration causes them to go into crisis. Hemolytic anemia, also these are normocytic anemias, G6PD deficiency, episodic RBC destruction. They have an inability to respond to oxidative stress. This is due to a hereditary enzyme defect that produces a deficiency in G6PD, and most common in African Americans of Mediterranean descent. This is usually diagnosed when a patient has an acute hemolytic anemia following an ingestion of an oxidative drugs, which I did tell you. Macrobid is one of them, quinolones, those are all, Dapersin, which is used for long-term leprosy. Hemolytic events are usually self-limited and mild, except in patients with Mediterranean form who can have more severe hemolysis. They may have a large spleen, aplastic crisis, pigment gallstones, and chronic leg ulcers. Risk factors for G6PD deficiency: presence of X-linked recessive gene occurs mostly in males. And these are medications that are oxidative and can actually cause a crisis as well. Quinidine is a cardiac arrhythmia. Nitrofurantoin is for UTIs. Macrobid is the other word for it. Pyridium. But these are risk factors, these medications, but it also can be genetic as well. Signs and symptoms: hemolysis only in the presence of oxidative stressors. During attack of hemolytic anemia, you're going to have an increase in RBCs. Indirect bilirubin will be elevated. The G6PD enzyme assay will be low. Peripheral smear might show bite cells or Heinz body or the specific stain, which are abnormal. So treatment of this deficiency, you want to avoid oxidative stressors. Episodes resolve spontaneously in supportive care. It's the treatment for this. Macrocytic, which is an MCV greater than 100. We're talking about megaloblastic B12 deficiency, folic acid deficiency anemia. Primary causes of macrocytic anemia: both vitamins are essential for DNA synthesis. So B12 and folic acid deficiency are the most common of macrocytic anemia because both vitamins are essential for DNA synthesis. Non-megaloblastic is due from liver disease, hypothyroidism, and alcohol. Macrocytic anemia, pernicious anemia, is deficiency of intrinsic factor, and this causes inadequate B12 absorption, impaired red blood cell synthesis. Most common cause of vitamin B12 deficiency. Occurs in all ages, in ethnic backgrounds, associated with autoimmune diseases. Pernicious anemia is a systemic disease. You have gastrointestinal tract involvement and neurologic involvement. Please remember that, neurologic involvement. So post-gastrectomy can cause this: bacterial overgrowth, autoimmune reaction involving gastric parietal cells, fish, tapeworm, and congenital enzyme deficiency. Risk factors: Crohn's disease, GI surgery, autoimmune disease, chronic E2H. A vegan diet can lead to B12 deficiency, okay? A vegan diet can lead to B12 deficiency over a period of years, but it is not pernicious anemia because it's not due to lack of intrinsic factor, but rather lack of B12 in the diet. Vitamin B12 takes 2 to 5 years to develop deficiency, even in the setting of severe malabsorption. And I did want to explain a little. Pernicious anemia is the most common cause of vitamin B12 deficiency. It's an autoimmune disease characterized by the presence of autoantibodies to the parietal cells in the stomach and the secretory products called intrinsic factor. Remember, intrinsic factor is essential for the absorption of vitamin B12 in the ileum of the bowel. And also it talks about autoantibodies. That autoantibodies, they mistakenly target your own tissue and organs, and that's what can cause this as well. So peripheral neuropathy is a classic stocking glove pattern, okay? It exists up to the knees and up to the wrists. So that's real important to understand with pernicious anemia. You have, for neurologic signs, increased, decreased deep tendon reflexes, decreased vibratory sense in the lower extremities, impaired proprioception, which is a sense of relative position of neighboring parts of the body. And the cerebellum is largely responsible for coordinating the unconscious aspects of proprioception. An example of that would be: patient closes their eyes, you ask them to move the finger up and down. Patients with eyes closed tells whether examiner is moving your finger up or down. That's proprioception. Glossitis is an inflammation of the tongue that causes it to swell in size. And that can be really nasty. Anorexia, peripheral, paresthesia, ataxia, trouble walking, tachycardia, and sclera icterus, which is the sclera of the eye is yellow, presence of jaundice seen in the eye. Diagnostic studies, you'll have a serum B12, which will be low. Methylmalonic acid, MMA, is elevated. Homocysteine is normal. Anti-intrinsic antibodies, one of the tests. In the Schilling test, it's a procedure, absorption of B12, and we measure urinary excretion of radioactivity. So the Schilling's test is done to determine if patient has pernicious anemia or solely a B12 deficiency. So basically, the patient consumes B12, radioactive B12, and the urine is measured for radioactivity. If the patient has pernicious anemia, the B12 will not be absorbed and will not show up in the urine. If the patient has a B12 deficiency but no issues with intrinsic factor, the urine will be radioactive. Patients with pernicious anemia must be treated with IM-B12 because they are unable to absorb it through the GI tract. Patients with B12 deficiency but without pernicious anemia can be treated with oral B12. Okay, so again, the pernicious anemia, patients drink the radioactive B12. They're unable to absorb due to lack of intrinsic factor, and no radioactive B12 will be in the urine. Patients who are severely B12 deficient, they can develop hypokalemia. So you monitor potassium levels as vitamin B12 is administered. So remember that as well. B12 treatment for B12 deficiency is 1,000 micrograms a day times 1 week, and then 1,000 micrograms times 4 weeks, and then 1,000 micrograms per month. Oral B12 is 1,000 to 2,000 micrograms a day for life. Again, I do want to emphasize that you have to monitor potassium, especially during the first week of therapy. Potassium may go way down, especially if patients are on diuretics or DIG therapy. Potassium is required to make red blood cells, so production of a large number at once sucks up circulating potassium. K should be monitored daily to 4 times in patients during first week of therapy. Patients without renal impairment should be given about 40 milliequivalents of potassium orally. Initially, what you'll see is that you'll see an increase in RBC once you treat them. You'll see reticulocytosis within 1 week. You'll see an increase in retic count, increase in hematocrit and hemoglobin within 1 week, and normalization of hematocrit and hemoglobin within 2 months. Rapid improvement in symptoms. However, it may take up to 12 to 18 months for all neurologic symptoms to improve. So, macrocytic anemia, folate deficiency, deficiency of folic acid needed for DNA synthesis, RBC production, and also the maintenance of gastric mucosa. Causes of folate deficiency: dietary, 90%, alcohol abuse, pregnancy, malabsorption related to celiac disease, or drug-induced. The treatment is oral folic acid supplementation. Bactrim and dilantin are one that can cause folate deficiency. Symptoms same as B12 deficiency, but more severe. No neurologic signs. Diagnostic tests: homocysteine is elevated, MMA is normal, and folate level low or normal. Remember, MMA is increase in pernicious anemia or vitamin B12 deficiency. increased values of 73 to 271 units of MMA is consistent with pernicious anemia. And what is that? It's a compound that reacts. MMA is a compound that reacts to B12 to produce coenzyme A. And this coenzyme A is essential to normal cellular function. When vitamin B12 deficiency occurs, MMA levels increase. Treatment of folic acid deficiency, 1 milligram per day. Duration depends on underlying cause. If related to malabsorption, may increase to 5. Avoid overcooking foods rich in folic acid. You want to assess retic count in 4 to 6 weeks. Should increase within 2 to 3 days and peak within 5 to 7 days, the retic count. Total correction within 2 months. Foods rich in folic acid are chicken giblets, kidney, egg yolk, dried beans, lentils, split peas, almond nuts, whole grains, wheat flour, potato, sweet potato, peaches, spinach, broccoli, and banana. We're going to go segue right into hemolytic malignancies. Most hemolytic malignancies are either leukemias or lymphomas. Leukemias and lymphomas are classified according to the stage of normal hemopoiesis, at which their neoplastic cells appear to be blocked. So it has to do with the bone marrow. Neoplasm is derived from lymphoid or myeloid cells, which are in the bone marrow, and they primarily affect the bone marrow and peripheral blood. Bone marrow makes abnormally large numbers of immature white blood cells, blast cells. You can have acute myelogenous leukemia, chronic lymphocytic leukemia, chronic myelogenous leukemia. So it's ALL, AML, CLL, and CML. And those would be diagnosed with a bone marrow. They basically attack the immune system. They're at risk for infections. They have anemia, weakness. They have no more regular white blood cells, red blood cells, and platelets. And blasts clog the bloodstream and bone marrow. Causes are high-level radiation, toxin exposures, viruses, genes, certain genes within the makeup of the patient, chemicals, and mostly it's unknown. Treatment is chemotherapy, immunotherapy, radiation, and bone marrow transplant. Non-anemic hematologic disorders, hemochromatosis, polycythemia vera, hemophilia, and ITP, which is idiopathic thrombocytopenia purpura. Hemochromatosis is an autosomal recessive disorder. It results in excessive iron stores in the liver, pancreas, heart, kidneys, adrenals, testes, and pituitary gland. An autosomal recessive disorder is two unaffected people who each carry one copy of the mutated gene have a 25% chance with each pregnancy of having a child by a particular disorder. Hemosiderin is a yellowish-brown substance that contains ferric oxide, and that's found in the thyroid, reproductive organs, skin, adrenals, pituitary, and thyroid gland. Etiology of hemochromatosis is an autosomal recessive mutation in the HFE gene, impaired transferrin-mediated iron uptake, increased intestinal absorption of iron, and the onset is usually at the 5th decade and is most common in men. Risk factors are family history, chronic alcoholism, iron supplementation, and type 2 diabetes. Signs and symptoms of hemochromatosis, they may be symptomatic, weak, dyspnea on exertion, abdominal pain. Their skin color is different, slate gray, brown skin pigmentation, large liver and spleen. They have problems with impotence, bleeding, and oftentimes they have heart failure. Diagnostic studies for hemochromatosis, the hallmark is liver biopsy. Patients might have mild elevation in liver enzymes. Serum iron level is elevated, and transferrin is greater than 50%. Treatment is paramount because if you don't treat them, they can get cirrhosis, CHF, diabetes, or become impotent. We want to make sure that they have low iron rich food. They will require phlebotomy for the first few years, and then every 2 to 4 months. And chelation, if they cannot tolerate phlebotomy, and oftentimes the chelation is secondary iron overload related to thalassemia. So you have to watch that as well, make sure that's not a diagnosis. Polycythemia vera is a chronic acquired problem with the bone marrow. It's a myeloproliferative disorder. This is characterized by overproduction of red blood cells, elevation of red blood cell mass and hematocrit. The risk factors are Jewish ancestry, family history, and exposure to myelosuppressive therapy. These are the symptoms: are headache, vertigo, ringing in the ears, blurred vision, itchiness, epistaxis, distended retinal veins, which is on exam. When you look at the optic disc, enlarged spleen, and history of clotting. What you'll see is an elevated hematocrit, an increased RBC mass, leukocytosis, thrombocytosis, basophilia, and leukocytosis is an elevated WBCs, thrombocytosis an elevated platelet count, basophilia is elevated basophils, and same with eosinophils, elevated eosinophils. Iron deficiency and elevated serum B12, and the bone marrow show pan-hyperplasia and basically an excessive growth of all of the cells. So the treatment is phlebotomy. Remove 500 cc's weekly until hematocrit is less than 45. Avoid iron supplements. Patients are going to be given hydroxyurea, which is an anti-cancer drug, and it suppresses the bone marrow. Also, they might need increased need for phlebotomy. And again, these patients are going to have severe itching. And thrombocytosis is an increase in platelets. Hemophilia is a hereditary disorder, deficiency of clotting factor 8 and clotting factor 9, hemophilia B. Produces reduced ability to clot. It's X-linked recessive trait. The majority of people who get it are males, and 85% are hemophilia A. So risk factors are offspring of affected parents, von Willebrand's disease. Signs and symptoms are bleeding after major insult, moderate bleeding with minor insult, and severe spontaneous bleeding. And von Willebrand's disease is a problem with clotting. Diagnostic studies, spontaneous bleeding into joint space is diagnostic. These patients have prolonged PTT. That's real important to know. Prolonged PTT. Their PT, their bleeding times, and the fibrinogen are all normal. Treatment for hemophilia, activity restrictions, avoid aspirin, factor transfusion. DDAVP is desmopressin to treat small bleeds. A lot of these patients have them. If you have a patient or someone that has hemophilia, they should have DDAVP on them at all times. Genetic counseling is required. This is an autoimmune disorder. Accelerated spleen-mediated platelet destructions. Patients present with decreased platelet count, decreased ability to clot, also known as ITP, which I'm sure most of you have taken patients with this. And so basically, IgG autoantibody binds to platelets. Splenic macrophages bind to antibody tag platelets and destroy them for this autoimmune disorder. Patients bleeding typically in the mucosa or derm. Patients have epistaxis, gingival bleeding, menorrhagia, which is abnormally heavy prolonged menstrual period, GI bleeding, petechiae, remember? Hemorrhage bullae of the mouth, splenomegaly, suggest other diagnosis if they have enlarged spleen. The differential diagnosis of bone marrow disorders, drug-induced thrombocytopenia, which is heparin, thiazide, Tagamet causes that, which would be your other differential. Sepsis, AIDS, or liver disease. Thrombocytopenia is hallmark, maybe platelets less than 10,000. Mild anemia, bone marrow is normal, PTT bleeding times are normal, and clotting factors are normal. Treatment for ITP is prednisone, splenectomy, high-dose immunoglobulin for emergencies, danazol if prednisone fails, and platelet transfusion if the patient is acutely bleeding. Immunosuppressive therapy if it's severe or there's refractory cases. Okay, guys, I know I went through a tremendous amount. We're going to go through a lot of this in class and through the case studies. Okay, I will talk to you all soon.